Osteoarthritis Pain, Recent Guidelines and Emergent Therapies. I'm Liew. I'm Assistant Professor of Medicine at Boston University School of Medicine, and I'm joined here by my colleagues who will now introduce themselves.
Hello, my name is Francis Berenbaum. I'm a rheumatologist, professor of rheumatology at Sorbonne University in Paris, in France, and also have a research team on osteoarthritis at INSERM Institute. Very welcome to be here and very thank you for this invitation.
Good morning. My name is Mohammad Ursani. I'm a private practice rheumatologist in Houston, Texas. I'm also adjunct faculty for the University of Houston's Internal Medicine Residency Program, and I'm happy to be here.
Our faculty disclosures are displayed on the bottom of the screen, and our program today is the second of 2 live streams about the management of osteoarthritis pain. So if you haven't already, please participate in the pre-test link above, and then after the activity, either participate in the post-test polls below the stream or follow the claim credit link to complete the post-test and evaluation and claim your certificate. Also, be sure to check out the OA tutorial posting early next week on the Twitter. So, over the course of today's discussion, we'll be addressing the following learning objectives. Describe the disease burden of OA, including the unmet need for effective pain management, and integrate communication strategies and patient-centered care considerations into routine clinical practice. So first, let's start with an overview of osteoarthritis. Next slide. OA is the most common form of arthritis affecting over 32 million US adults. We think of it as a disorder of the whole joints and not just of the cartilage. Pathophysiology is characterized by cartilage destruction as well as bone remodeling and synovial membrane inflammation. The prevalence is rising consonant with the aging population and increasing rates of obesity. OA is a leading cause of pain worldwide and the 15th leading cause of years lived with disability. There is also a high cardiovascular disease burden in OA, owing in part to shared comorbidities and risk factors. The currently therapies target symptom control and none are disease modifying. Next slide. So risk factors for OA can be broken down into these 3 green boxes: modifiable factors, and then modifiable local factors, modifiable systemic factors, and then non-modifiable systemic factors. Risk factors can also be broken down into those that lead to a joint being susceptible to OA and factors related to the individual who is then said to be predisposed. So modifiable local factors that lead to a susceptible joint include muscle strength, particularly in the quads and hamstrings, physical activity or being sedentary, prior joint injury such as injuries to the ACL or the meniscus, joint malalignment, leg length inequality. Individuals may be predisposed to getting OA due to modifiable factors such as obesity or diet, but also non-modifiable factors like age, sex, and other genetic factors. Next slide. So again, OA represents total joint failure and not just wear and tear. Muscle weakness can lead to changes in the tendons and ligaments and their ability to function. The synovium can become inflamed and release cytokines and other factors that promote further inflammation as well as collagen breakdown. And then you can see on this slide cartilage destruction as well as meniscal derangement, which is common in OA knees. And you can also see new bone formation in the form of osteophytes. Next slide. So signs and symptoms of OA in the common sites. So we've got the hands and knees and the spine here. So in hand OA, you think of involvement of the DIPs, which you would not see in RA. This can be marked by hypertrophy or the nodules you would see on exam. The PIPs can be involved as well with nodules there. And the base of the thumb, the first CMC joint, can have localized tenderness. In the knee, this is what we think of as a mechanical type of pain with movement, improvement with rest. However, individuals can also have subjective swelling or objective effusions on exam, and they may feel crepitus or instability when walking. And in the spine, you can have limited pain range of motion with or without pain. And if there's spinal stenosis, they may have pseudoclaudication symptoms. All right, so now after this section, I'd like to get some thoughts from my colleagues. So our discussion topic for this first section is, what do you think are the most persistent unmet needs in OA management today?
So maybe I can start. I think that there are a couple of unmet needs in OA. The first one would be when OA happens in young people. So if you consider someone with a ski accident at 20 years old, if there is a meniscus tear, problem of ligaments, in the 10 years after that, maybe half of these ones may have an osteoarthritis problem. And so if you have OA at 30 or 40-year-old, then this could be really a very big problem. You really do not know exactly how to manage this kind of problem. So I would start by this one.
Okay.
Yeah.
To add on to that, I think Dr. Liew had briefly mentioned it, where for other types of arthritis, such as rheumatoid arthritis, there's currently disease-modifying agents, where we're able to prevent the progression of the disease pathology using certain medications. Unfortunately, for osteoarthritis, we don't have those agents as of yet. A lot of the treatment that we have is more symptom control and pain management, as opposed to joint reconstruction itself, at least pharmacologically. So I think that's a large burden or a huge shortcoming that we face today.
These are great points. So,
just maybe another unmet need, I think, which is important, is we sometimes consider that with a total joint replacement, the problem now is not there anymore. In fact, we know that 20% of the patients that will have a total knee replacement continue to have pain. And so this chronic pain after total knee replacement is a very huge problem and a real unmet need.
these are great points. So young people who may have a post-traumatic OA after an injury, and then the fact that joint replacement would be a difficult discussion to have with someone who's like 25, 30. The fact that we don't have any D modes to modify disease and to treat pain or structural progression well. And then the lack of an ability to enrich for or identify people who may not respond totally in terms of symptoms to a total joint replacement. So it sounds like these are three pretty different but also connected topics of unmet needs. So hopefully we can go over more of these today. Dr. Ursani, could you discuss the burden of OA and OA pain with us, please?
Sure, absolutely. So let's discuss a few interesting points. The first paper that represents this representative of this slide was a paper that was published in 2019, but it actually looked at data from 2015, focusing on medical expenditure on U.S. adults aged 16 to 64, and it compared those with osteoarthritis to those without osteoarthritis. On the left side of the screen, interestingly enough, it had suggested that about 24% of individuals that had osteoarthritis had a severe amount of pain, which caused interference with activities, as compared to 7% or just shy of 8% of those without osteoarthritis. Same goes with the moderate interference with activities with individuals that had OA was about 17% versus 7% of those without osteoarthritis. And those without osteoarthritis significantly had none or mild symptoms of pain that would interfere with their daily activities. On the right side of the screen, it's aside from just functional limitation or physical symptoms, we have to remember that Beyond this, we have to know that osteoarthritis also plays a role in terms of social activities and cognitive functions disability. So with individuals that had OA, they had a significant more limitation when it comes to both social activities with their community, as well as cognitive function abilities, as well as limiting work. Next slide. So aside from the physical aspect, OA also has an impact on the emotional well-being of individuals. This was a study that was published in 2021. It showed that about what the study had looked at was individuals with knee osteoarthritis. About the average age was about 63 years old. And it was a good split between both female and male, about 49% being female. Depression severity and knee joint symptoms were assessed using the PHQ-9 and the WOMAC indexes at baseline and at 24 months. And what it revealed was that the presence and incidence of depression was about 25% at baseline and 11% respectively at the end of 24 months. At baseline, individuals that had osteoarthritis, the depression was associated with younger age, as Dr. Berenbaum had previously mentioned, higher BMI, a higher WOMAC pain score, lower education level, more than 2 or more body parts that were affected, and more than one comorbidity. And a little bit later slide, we'll discuss some of the comorbidities. At the end of 24 months, the factors associated with the increased incidence of depression were associated with female sex, increased WOMAC pain scores, as well as more than two or more painful sites. Which, in conclusion, what the study was suggesting that managing both common osteoarthritis risk factors and joint symptoms may also be important for preventing and treatment depression in patients with knee OA. Next slide. From the first paper that was mentioned, looking at the medical expenditure data, they had also looked at out-of-pocket costs and total costs for individuals with osteoarthritis in the United States. Not only was the out-of-pocket cost higher for individuals that had osteoarthritis by about $200, but also the cost for third-party peers was also significantly higher at about $1,500. In addition to this, individuals that had osteoarthritis also were found to have wages lost from work due to missing work related to the pain by about, again, shy of just $200. Next slide. So from the patient perspective, the most common symptoms that impact the daily activities include pain and tenderness, stiffness, walk disturbance, loss of flexion or flexibility, sleep disturbance, fatigue, swelling. These symptoms are important to address when discussing treatment plans or discussing disease burden with patients. Because they can give you an idea of what their goals are and how you can help manage treatment so that their condition is stabilized according to how they feel. Okay, next slide. So this study was published in 2020, and it actually looked at a data set or a patient population from both the United States as well as the European Union. Predominantly, it was the European Union, about 75 to 25% in the US. What they looked at was not only the VAS score, but also the 5L or the European EQ 5D 5L 5-dimension Euro quality of life score. Their aim was to evaluate from the patient's perspective the burden of pain associated with hip and knee osteoarthritis. The study had about 2,200 patients. About 55% had, about 25% had hip OA, 20% had knee and hip OA, and about 55% had knee osteoarthritis. What the results had shown was that the impact of OA pain is worsened by increasing pain intensity and may not be accurately addressed by current treatment strategies, given that the people that had the worst scores were the ones that had moderate to severe related pain or OA related pain and were in opioid use. And those results are very similar in both the US and European cohort studies, suggesting that perhaps in severe pain or in patients that report severe pain related to their osteoarthritis, we don't have adequate symptom management, even with the use of opioids. Next slide. The same study looked at whether their pain indices and the use of opioids were related to or could correlate with absenteeism from work or presenteeism to work, but with just limited function. And the data was very clear in displaying that individuals that had more moderate to severe pain related to the osteoarthritis and that were on opioids had a significant amount of time that were missed from work altogether, more so in the European patient group as opposed to the United States. But across the board on presenteeism, where individuals would come to work but would feel limited due to their disease pain related to their osteoarthritis. Again, suggesting that osteoarthritis is the symptoms of it can impact more than just the individual patient, and it can impact the larger community or even their workplace. Next slide. So the data suggests that individuals with OA are likely to have other chronic conditions, with more severe OA being associated with an increased number of comorbidities. So it's important to remember that association is not causation. Why this is important is clinicians have to remember that when treating patients with OA, the burden of OA is compounded by the presence of these other conditions, such as hypertension, hyperlipidemia, depression, peptic ulcer disease, heart disease, kidney disease. And the other reason why it's important is that when assessing to treat patients, we have to be cognizant of the other comorbidities that they may or may not have. For example, if someone has peptic ulcer disease or chronic kidney disease, it is not advisable to use NSAID therapy or nonsteroidal anti-inflammatory drug therapy, although it is approved for osteoarthritis-related pain. Next slide. And this was an interesting study that was a meta-analysis of 61 studies looking at OA-related pain and the severity of the pain that was stratified by race. What it suggested was that African Americans with osteoarthritis reported a greater pain and disability compared to non-Hispanic whites. They had a higher clinical pain severity with both WOMAC and non-WOMAC scales. They reported more functional limitations, and they had a poor performance on functional tasks such as timed walking test. The clinical pain severity and disability in African Americans should be explored in future study, just so that we can find the reason for these differences, again, to improve pain management and quality of life. And from the prior slide that Dr. Liew had mentioned, some of these are non-modifiable risk factors, which may play an important role in management of OA going forward. So at this point, I'd like to invite my colleagues back to discuss more about the burden of OA and OA-related pain.
So in the prior discussion, we talked about some unmet needs. So people who are getting OA at younger ages, lack of D modes. and then what to do when the definitive treatment, joint replacement, does not take away enough of the pain that was previously impacting their lives. So in addition to these things that we've already talked about, what are some other important contributors to the burden of OA overall?
Maybe the additional burden could be also, and Dr. Ursani has very well presented the problem of the comorbidities that could be a very important problem when you, as a doctor, you have to choose a treatment because of these comorbidities. Sometimes you cannot prescribe NSAIDs because there is a contraindication, like an history of myocardial infarction. You cannot prescribe opioids because, due to the age of the patient, 80-year-old, you expect that there will be a problem with that, falls, confusion, constipation. And so at the end, you do not have any possibility for medical treatment. Of course, it's important to consider the non-pharmacological treatment, but in elderly people, it's not so easy. So I would like to add that also on the list.
And I think one other thing is, or one of the other contributors or burdens of osteoarthritis is that a lot of the times both healthcare providers and patients see it as a quote unquote fact of life that they're just getting old. The more that we study with osteoarthritis, we realize that that's not always the case, and most times that's not the case. And so because of that, there's a barrier to being treated earlier, being assessed for treatment early. And as when we change that mindset, or hopefully when that mindset changes, then people will be able to come and seek care a lot earlier.
Okay, so limited options, especially in the pharmacologic realm, and then this view that there isn't much that can impact the progression or really even the impact of OA pain on just daily life. This kind of view that maybe there isn't much that could be done. But yes, based on what we just discussed, it's clear that patients of OA face these significant challenges that are compounded by this current lack of really curative treatments, and they face significant challenges also in achieving better health and quality of life. So in general, what do your patients with OA articulate as being their most important health-related goals?
There is a long list of potential limitation in their activities, but each individual has his or her own list. What I mean by that is, as an example, you will have someone, for example, who consider that gardening is really what is important for his or her life, and because of OA, this individual will not be able to do gardening anymore. And this could have a very big impact on the quality of life, leading to depression, as you have mentioned at the beginning. And so another one, it will not be gardening, it could be dancing, it could be, of course, sport like skiing, or I don't know. But what is very important is to listen to the patient in order to know what really is the objective for this patient you have in front of you, and not considering that all people have the same objectives. And I think this is very, very important.
Yeah, I completely agree with Dr. Berenbaum. You have to look at the patient. Every patient has their own individual circumstances. I can recall a patient that lived in a 2-story house, but never wanted to go up the stairs because of the knee or their hip osteoarthritis and how much pain it had caused them to be mobile. And so when patients start to tell you their concerns, I think that should be, number one, the focus of treatment, the focus of reassessing how poorly or well the treatment is going, as opposed to typically clinicians, what we look at are things like pain scores or WOMAC scores, but or radiographic progression. Sometimes those don't align, or our objective measures don't align with real world examples that the patients are living day to day.
Right. These are good points that we need to elicit the individual goals and then work with our patients to see what avenues are available to reach these goals, and also the limitations of our measures of our outcome measures. So radiographic OA doesn't always correlate with pain levels or functional limitations, and then things like the WOMAC score, while used in studies and clinical trials, they don't really capture the fluctuations in pain that people might experience. They're just not they're not the best measure for like daily symptoms, even though it's a really good measure and one of the better ones that we have.
Yeah.
So what kind of approaches? Sorry, go ahead.
May I mention another one which is not so easy to speak on, and I'm thinking about a taboo problem that patients find difficult to mention spontaneously, especially in case of hip OA, which is the impact on their sex life. This problem is actually included in very few tools, a few index. I remember one, I think, in a quality of life scale for hip OA, but it's not so frequent that you see that, and it could be a big impact for hip OA, also knee, but mainly hip OA. So we really must listen to this, and for that you need to have your patients in a confidence when you are in front of the patient. So the informal discussion is very important, because maybe at the end, after maybe 10 minutes, you will catch this kind of problem, for example. It will not at the first minute, and it's important.
That's a great point. So go ahead, Dr. Ursani.
No, I was saying this absolutely. I was agreeing with everything.
Okay, so I think we have talked about a lot of ways that we could elicit goals from patients, as well as good examples of what individual goals might be, including ones that we don't typically think of if we're running down a checklist of goals, like asking, or symptoms like asking people if they have issues walking on stairs or issues at rest. But what about all these myriad other issues that they might face in their daily life? So I think we should move on to our next section. Dr. Berenbaum, could you guide us through multidisciplinary patient-centered management of OA, please?
Yes. So now, may I have the previous slide, please? Just for introduce the topic, because it's not a very usual topic about the multidisciplinary and the patient-centered management. Because every patient with OA is different, you will need to tailor your recommendations by using a multimodal and individualized approach to address the symptoms. And in fact, the most effective treatments depend on patient behaviors like weight loss, increasing physical activity, and participating in self-management programs. And this is very hard to achieve, I would say. So in the next slide, I will describe some tools we can use for changing behaviors, and so to decrease the burden of OA for our patients. So the first of all is to consider that it's really essential to bring together all the health professionals around the patient, and each with a clear objective. So you can see on this slide, and maybe just the next one. Please, the next slide. Yes, thank you. So you see, for the patient, what is your objective? Your objective will be the exercise, of course, usually also strength training, for overweight patient, the weight loss, you would like also to prescribe some drugs, so oral treatments, sometimes also intra-articular agents, some biomechanical interventions, self-management, education, and you see all these experts around that each one will have an expertise. And so it's essential to select a coordinator for that. Usually, I would say it could depend on the country. In France, it's the GP, usually, which is at the center, the coordinator. It could be also a rheumatologist in some countries. In France, also the rheumatologist is at the core at the heart of this multidisciplinary team. But what is very, very important is to consider that the patient is at the heart of the system. Next slide. So let's take now a case study, a practical example with Martha. So Martha is a 65-year-old African American woman. She is recently retired. She was a teacher, and she's now is a primary caregiver for her 6-year-old and 4-year-old grandchildren during the week. About her medical history, she has hypertension, she is pre-diabetic and overweight, so the usual patient with a metabolic syndrome. And she already performed X-rays a long time ago, you see, nine years ago, and there was OA on these X-rays of the knees. The pain management, she's on NSAIDs. She also have a program with low impact exercise and a diet for weight loss. Next slide. And so when you speak with with Martha, you see that the control of the symptoms is suboptimal. She still has stiffness and pain in the morning. She has difficulties for climbing the stairs due to the pain. She has fatigue, and especially when she has to take her grandchildren to the playground. About the weight, it's not so good. She achieved rapid and significant weight loss several months ago, but she gained most of the weight back. And this was not the first time. This also happened a couple of years ago, again with a weight loss, and then again the weight came back. And so, of course, she's frustrated because of she's not able to have a sustained progress for this weight loss. She has more and more difficulties for adhering for the dietary recommendations, and she also do not see a benefit for the stiffness, the fatigue with all the exercise. She's not very happy with that. Concerning the physical exam, she has a decreased range of motion, mild tenderness, some crepitus, and also a mild synovial fluid effusion. So this is the case to discuss on today. And I'd love to hear my colleagues' thoughts about our patient, about Maria.
Okay, so in this case, we have covered some of her goals of treatment and then a multitude of things that she's tried and some things that have not really worked out well for her. So during follow-up visits for patients like Marta, what types of strategies would you use to ascertain her goals further, figure out what she wants to gain from treatment and management, and whether or not her goals are being attained?
So she kind of highlighted. Sorry.
Yeah.
what was important to her. I mean, her weight is clearly important to her because she's addressing that with her physician. And also being able to keep up with her grandchildren is also very important to her. So when trying to assess her disease activity or her disease burden, I think focusing on for example, those 2 points is going to be a good measure of how she feels about her arthritis.
Yes, I personally use some tools to assess the problem. I like to use the Lequen index, for example, mainly for the hip, but also for the knee. And on this index, you first the patient um, is happy to have someone who is asking the good questions. I mean, the questions about the daily life. And this is exactly what is this kind of questionnaire. But in after that or before that, depends. It's also fine to have an informal discussion. Once again, we already discussed about the fact that each individual has his own objective, and so it's a mix. It's a mix of standardized questionnaires and also informal discussion.
Okay, so that really highlights the types of things, not just questions, but letting the patient talk about what they find is important to them, and just hearing about the details of their daily life. And you can already glean without even asking them questions directly what's important and what their goals might be. Do you have any strategies beyond interviewing them or asking them questions and beyond the physical exam for really highlighting what other goals or what other shortcomings of their current treatment plan there might be?
Well, I think as Dr. Berenbaum mentioned previously, I mean, you have to have a multidisciplinary approach. So, for example, in the case of Martha, her main concern that she's telling us in so many words is seems to be related to muscle conditioning because she's unable to keep up with her grandchildren. So, I think having the role of a physiotherapist or physical therapy kind of embedded into her treatment algorithm is very important. And then also having with her concern of her weight, making sure that she's in touch with a nutritionist or spend some time discussing nutrition very specifically in order for her to, again, progress her own individual case further and decrease her personal burden of osteoarthritis.
Okay,
Yeah,
so
I agree.
connecting her with more specialists. And then what are your specific concerns with her currently in terms of what she's described so far? Do you have any concerns about her her own approach to her goals or her progress to date?
In fact, for me, my specific concerns is that uh, OA is there for a very long time. It's now around 10 years that she has this problem, these symptoms, and she already tried what we usually prescribe about the non-pharmacological and pharmacological approach. So she received the good prescriptions, but 10 years after that, she keeps on having very important burden. And so I think this for me is my concern, because what are we going to do now?
Right. And then I think her like sustained her lack of sustained progress with diet, exercise, and weight loss. She probably is feeling really resigned and frustrated, and probably feeling at this point maybe it's not going to get better. Maybe she's already done everything and there's not much else left. What strategies do you have when that happens? If a patient brings up those concerns like this, maybe this is just never going to get much better for me.
Yes, so maybe we can go to the next slide for explaining what could be these strategies.
Okay, could you go to the next slide, please?
Yes, so no, yes, this one. Thank you. So the first tool I would like to highlight for counseling patients with OA about behavior change is what we call the motivational interviewing. So this kind of interview is a technique in which you become a helper in the change process. It aims to encourage the patient's autonomy in decision making, where the clinician acts as a guide. In other words, instead of imposing directives on the patient, you help them understand where their barriers and how they can overcome them. These on this slide are some example. So just look at this example. The standard approach could be, as your HCP, I really think that you should exercise on a daily basis. So you should exercise. The motivational interviewing will be, what are your thoughts about exercising? You see the difference? You switch from you have to do that to, okay, let's discuss what are your thoughts on that. Another example, there are all kinds of ways you could exercise. You could walk, ride a bike, swim, or go to a gym. So this is the standard approach. The motivational interviewing will be, what kind of activities do you enjoy? So once again, it's a little bit like the previous one, is you move, you switch from you can do that to, okay, discuss about what could be the activities you would enjoy. Because then, for example, if the choice will be, oh, I really like swimming, then you will discuss on that, how you can do that. Are there any swimming pool close to here, and so on. So this is very, very good example. Another one, you say that you don't have time to exercise, but exercise is so important for your joints. You should make time for it. You transform that and you say that time is a barrier for you to exercise. What ideas do you have to fit physical activity into your daily routine? Once again, you should do that, and you move that in a motivational talk by, okay, what ideas do you have? You see once again the difference. And I really want to look at all these examples, because then you can try to take these examples, and for your next consultation, you will try to do the same. I have written some goals for you about increasing your exercise. So it's only on one way, from the doctor to the patient. And the other way is, tell me what you would like to work on for the next 3 months. And the last one is, you say you want to be more active, yet you don't do the home exercise program I gave you. This tells me that you just are not interested. So this is very, very negative. This is quite evident that you need to change this kind of sentence, and which could be, your ambivalence about exercise is normal. Tell me how you would like to move forward. So once again, very, very important to modify the fashion you speak to the patient in this kind of way. So next slide. Another tool you can use, and this tool is called the brief action planning. This relies also in part on motivational interviewing, but this is maybe more a structured self-management support technique. It will assist the development of an action plan. It uses a combination of specific questions and provider-led discussion, and the goal is really the specific health behavior change that the patient feels is manageable and realistic. and you will build by this way patient self-efficacy and promote health behavior change. So on the left, you see the first question is there anything you would like to do for your health in the next week or two? And why this question? Because there is a universal human and human need for consistency, and so it facilitates the development and commitment to a concrete action plan. The second question is that you ask the question, how confident or sure are you about carrying out your plan? By this way, it will increase the likelihood of success of an action plan. And the last question is this one: would it be helpful to set up a check on how things are going with your plan? And by this question, this will introduce accountability, which also increases the likelihood of the success. So previously, we see what is a motivational interviewing, and this is maybe deeper, more detailed, is an action plan based also on this kind of motivational interviewing. Next slide. And the third and last tool I wanted to highlight is what we call the shared decision making. So this is a process of communication in which clinicians and patients work together to make optimal healthcare discussions and healthcare decisions that align with what matters more to the patient. And for that, of course, it will require an unbiased, clear, accurate medical evidence on treatment options, and also including the fact that sometimes there is no treatment. So this is the first way you will have to tell to the patient the medical evidence. Then there is the clinical expertise in communicating the relevant evidence. So on what first point there is clinical evidence, the second point is to communicate that with a relevant way of communication. Of course, there is a need for the patient values, the patient preferences. You have to listen to the patient for that. And at the end, you will have the patient empowerment and the partnership in decisions that will impact health. So you have seen here 3 examples of how you can ameliorate, how you can increase the way for better communication with your patient. And at the end, this will lead to a higher success of what you are prescribing to your patient. So now I would like to hear some thoughts from my colleague, Jean, Mohammad.
All right. So what strategies have you personally found to be the most effective? What kind of language have you used with patients that you have found has been really effective in either doing motivational interviewing or getting together an action plan for the patients?
So personally, for me, it's really the motivational interviewing. So the plan, I have not yet do that, but the motivational interviewing, shifting from saying what the patient has to do to let's discuss. And that for me is really a very critical change in my fashion to discuss with my patients in the last years.
Yeah, so I think that the common theme of all 3 examples of strategies that were highlighted was basically make the discussion patient-led. So as opposed to the physician telling the patient or the provider telling the patient what to do, as long as the discussion is patient-led, that'll lead to the likelihood of motivation and kind of a shared decision-making plan, you know.
Right. Because you could say, well, I think physical therapy would be helpful for you, but then perhaps they live far away from an available physical therapist, or they can't find time in their work schedule to do that. But something else that might work for them is if they enjoy long walks, like with their dog, or if they have thought about doing aquatic therapy in the pool and they bring that up, that is something that they could try, and then you could check in on their progress and just seeing how that worked for them, instead of saying, well, I think you should, or here are things that we would recommend. So I think whatever physical activity they're interested in, that they want to do, that they feel that they can actually accomplish, that's probably the best physical activity that they should do.
Yeah.
And then
I think this is really the most challenging objective for our patient is physical activity and weight loss. This is very, very difficult, and we have to accept the fact that there could be some period where the patient is not successful, and we have to accept that, but we have to continue on be delivering optimistic statements. As an example, okay, you have not been able to lose uh, um, 20, 20 pounds, but even if you just lose 10 or maybe less than that, then it will be already a success. And so, okay, we will go step by step, small step by small step, and not having saying that the objective is 20 kilograms to lose, and this will not never be small step by small steps. This also is well accepted by the patient.
right. And let's see, any other thoughts on these things that we've discussed here today, either this last section or any of the sections that we've talked about at all?
Yeah, I really think that the treatment for OA does not rely on drugs. This could be helpful in some period, when there is a flare, but we really think that the non-pharmacological approach for treating OA is so important that you have to spend time on that, and not just prescribing an NSAID and say then you come back in 3 months or in 6 months, and then we will see. What is very important is to see the patient as a whole, to see that the patient may have also diabetes, hypertension, other aspects of the metabolic syndrome, and so to discuss with the patient that you will not only improve your pain, but by this way you will also improve the other comorbidities with a very important impact for your life in the future. If you so it's a whole, and this is very, very important. The second aspect I would like to highlight is that according to the phenotype of the patient, you will not deliver the same messages. And when you have a 30-year-old patient, sport and so on, discussing about physical activity is not very impactful, because the patient is already performed maybe much more physical activity than you. So the discussion will not be around the same points. And so it's very, very important to keep that in mind, that it's really based on the phenotype, what I call the phenotype, that you will deliver the message.
Thank you for those thoughts, Dr. Berenbaum. Dr. Ursani, do you have any other closing thoughts?
No, I think Dr. Berenbaum hit it right on the head, where you treat the patient as a whole, make the approach multifaceted, and understand the goals of the patient, and put those ahead of your own goals as a clinician. And I think that's going to end up having the best overall outcomes for the patient.
Letting the patient lead. That's a great close. So I'd like to summarize our program now. Thank you, everybody. So OA imposes a substantial burden on patients due to its pervasive negative impact on physical, emotional, and economic well-being, which we've discussed today. Patients with OA report significant interference with activities directly related to inadequate pain management, despite all the interventions they've tried, like our patient example that we had today of Marta. And then to help patients achieve disease management, strategies for promoting patient-centered care and effective communication are needed to ensure accurate symptom control assessment, as well as optimal patient education, engagement in their own care, and their self-management, as we described with the action plan and motivational interviewing. So our time today is up, and thank you to our audience for joining us today for the second live stream. Please make sure you claim your CME credits by completing the post-test and evaluation form at the URL that's located at the bottom of your screen today, and have a wonderful rest of your weekend. Bye.